Good afternoon, everyone. Welcome to a session of the Globe Summit, the Boston Globe's annual conference this year, 2023. Thank you for joining us, both in person in Boston and virtually out there on the web. My name is Rebecca Mashuris. I am the Mass General Brigham Chief Medical Information Officer, and I will be moderating today's panel on the impact of applied AI in healthcare. So I hope you're all excited as I am to be joined here by my colleagues from MGB. And I will introduce each of them, and then we'll get going with some discussion here. So first we have Bharti Khurana, who is an associate professor of radiology at Harvard Medical School and a practicing emergency radiologist at Brigham and Women's Hospital. Her research focuses on meaningful interpretation of imaging, particularly for patients who have experienced domestic violence. Next, we have Alex Denadai, who's an assistant professor of psychiatry at Harvard Medical School and a data scientist at McLean Hospital. His research focuses on the use of big data to improve mental health diagnoses and treatment, very important topic. And last but certainly not least, Leisha Sequest, who's professor of medicine at HMS and a practicing medical oncologist at Mass General Hospital. Her research focuses on developing new tools for the early detection and prediction of lung cancer, very hot topic in the news lately as well. So let's dive in. I will start out by saying that AI, I'm going to make a bold statement. AI is changing our lives fundamentally in all aspects, right? Everything from my being able to identify pictures of my kids from when they were babies amongst thousands of pictures in our Google family album, to using ChatGPT to explain really complicated concepts that I know nothing about, to making me into an artist or a poet, which I am most certainly not. And AI is also starting to pervade healthcare in ways that it hasn't over the last few decades. I think particularly in radiology, we have seen the use of what's called analytic AI for many, many years, decades, in fact. And it's only now with generative AI that we are seeing it invade into other areas and other aspects of healthcare. And that's causing, I think, a real frame shift in how we are going to approach healthcare delivery, medical training, and our patients' and clinicians' experience. So with that, I'll start out with a question for each of you. And not trying to go totally wild and predict well into the future, but staying a little bit closer to home. How do you think AI will change healthcare in the next 3 to 5 years? Bharti, maybe we'll start with you.
Sure, thank you. So before I answer this question, I'll take you to the past. In 2016, when Geoffrey Hinton famously said that we need to stop training radiologists because in 5 years, AI will do much better than radiologists. So this was in 2016, and this was like sky is falling moment for radiologists. And we had those moments before too. In the past, for example, when we went to all digital from films, I remember I was a second-year resident at the Brigham, and I was just thinking, who would ever come and consult me, because now everybody has access to imaging. But that didn't happen, fortunately. But it wasn't that I was skeptical. I was an emergency radiologist, practicing emergency radiology and training the new generation of radiologists. So when I heard that statement that computers are going to replace radiologists, I decided to embrace AI, learn more about AI. So I didn't have any computational science background. But I started taking classes in AI. I started actually sitting with data scientists, learning about their challenges and perspective. So now in 2023, presently, I still have my job. AI hasn't replaced me. And unfortunately, we are extremely short-staffed. Actually, just before coming also, I was getting these pages. So I promised them once I come back, I'm going to review studies. So we are definitely short-staffed. I see AI in 3 to 5 years in 3 ways. One is I'm seeing AI as an assistant, helping me with my cases. So some things which are tiring, which are mundane, which are just like making measurements, comparing and giving size, those things will be done by AI. So AI will become my assistant. Secondly, even with the automation, so right now I have a huge list of cases to read. I don't know which one is urgent, but AI will automate that for me, and it will highlight the cases which need my urgent attention. So that would definitely happen. So I see AI as an assistant. But I also see AI as a superhuman in 3 to 5 years. So things which I am unable to see, AI will be able to show those things. For example, it is already happening. You'll hear more about it. If I see a tumor, I don't know the genotype of the tumor. But now with AI, we have that capability. AI can predict the genotype, the prognosis of that lesion. Similarly, there is so much information. When I'm reading a study, I'm just saying whether there is pulmonary embolism or not, whether there is a clot or not. So I'm reading qualitatively. I'm ignoring all that quantitative data which is there, but I'm not reporting it. So I definitely see AI doing that work. So this is like superhuman. And then the third aspect is humanitarian. We know that we are going to be very short-staffed in 10 years from now. I have heard like there'll be a shortage of tens of thousands of radiologists all over the world. Right now at the Brigham, we have 24/7 coverage, but it's not everywhere. How about some parts of the world where tuberculosis is still rampant and there's no one to interpret radiographs? So I do see that humanitarian aspect too, where AI is going to screen all those patients where radiologists cannot reach. And that would be, so this is the vision I have from, and again, it's in 1 year, our life has changed with ChatGPT, so who knows what we are going to learn.
And it's also a sense of a local, a national, and an international impact, right? That I think you're describing, which is really important as we think about these tools. Alex?
Yeah, it's a fantastic question. It's a really exciting time to think about this. Two things come to mind most prominently to me. The first is error prevention, in that medical errors are the third leading cause of death in the entire country after cancer and heart disease. And by definition, these are preventable deaths. And AI, I think, is particularly well suited to address these things, in that the problem is in medicine, there's so many moving parts, it's hard to keep everything in order, whereas AI can keep millions of things in order at once. And it's also very good with things that are rare to individual people, but actually not that rare on the public scale. So for example, if there's a medical error in 1 in 1,000 cases, that means, if you're the provider, you've succeeded 999 times, but that's going to mean tons and tons of errors over time. And AI is very good at tracking these things that are fairly rare, but not super, super rare. And so I think that's one issue it can do well as. The other that comes to mind is thinking about what it's going to look like. And as just mentioned, kind of like ChatGPT came out of nowhere. And I think if you look at the history of AI and computer science more broadly, it usually takes an exponential path that you kind of see slow, 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 and then it accelerates quickly over time. So like I remember 18 months ago, people talking about GPT-3 and saying, this thing is out there, whatever, and then ChatGPT is GPT 3.5, and all of a sudden this is on all of our news headlines. And I suspect we're going to see a lot of incremental things that might take off in ways that are surprising. Again, there's a lot of precedent for these kind of things over time. Like, for example, in the 70s, they have people talking about smartphones and what they might be like, and there was a lot of predictions on when they might happen. Some people said it might be by the 90s. Some people said, no, this is a 22nd century thing. And what honestly happened was these incremental advances that happened over time, but then in the mid-2000s, you saw this real inflection point where things took off. And I suspect we're going to see a lot of this in healthcare as well, with a slow build, some cool things that show up, but then a lot of things that just come out of what seems to be nowhere but are really exciting.
It's really exciting and absolutely true, right? We saw this exponential rise. If you look 18 months ago, there is basically no mention of ChatGPT in the news anywhere. And now you can't read a newspaper without seeing something about generative AI and ChatGPT. And part of that actually was making it accessible, right? GPT, the original, was just a large language model built on terabytes of data and billions of parameters, right? But then they layered on this chat feature, and that made it incredibly accessible to everybody, really. And so again, thinking about the broader implications and broader applications of this technology, and what we've seen in radiology for decades is predictive analytics and analytic AI, and now we've moved into this generative AI space, which allows us to do a gazillion more things. So, Leisha, your predictions?
Yeah, it's these were both such great answers. I mean, I think that because ChatGPT has been in the news so much, I think a lot of the public has maybe some notions about how it might be in medicine that aren't exactly aligned with reality, because we know that sometimes if you're playing around with ChatGPT or something like that, it can come up with some ridiculous things. And so I think, what we have to realize is that in medicine, there is so much data, and it's not necessarily someone reinventing the book about how to take care of a certain, using ChatGPT to come up with a new treatment. Really, I think how AI is going to interface with medicine is in helping us sort through these mountains of data that we're generating with our images, with our genetic testing, with all of the vital signs that we collect on people over the years, all of the standard labs that we collect over the years. We're not really doing anything with that data other than just looking at it in the moment. We're not understanding the trajectory of people's health the way we could be if we engage with tools that can handle big data, that can see patterns that the human brain doesn't necessarily recognize. So I think we could really actually take much better care of our patients if we have the right tools at our disposal. It's not that an algorithm is going to interface with the patients and you don't need the doctor anymore. I think that you still need that human to put it all together and to interact with the patient in front of you. But I do think that it's going to allow us to understand so much better what's happening with patients and what might be about to happen, to predict what might happen next for the patient in front of us.
Yeah, it's a really good point. And I think also a really important point that what you're reading in the news may not be reality of how we are using these tools today to take care of patients, to take care of ourselves as clinicians, to take care of our colleagues, in that, yes, we use predictive analytics rampantly in healthcare, right, to try and predict who's at risk for clinical deterioration or who's at risk for a disease onset, and we use it in radiology, right, to do some of that imaging diagnostics. But generative AI really is in its infancy in healthcare. Particularly at Mass General Brigham, right, we're starting to use it in the administrative space. So using generative AI to help clinicians write their notes, to summarize charts. But we have not yet really put it into practice with real humans, generative AI, in healthcare. But the three of you are actually working on some really exciting things in that space that hopefully will come to fruition and are starting even now to get there, but to come to fruition in kind of the care of real world patients. So I'm wondering if each of you could talk to us a little bit about what you're doing and what's exciting in your kind of specific research area. Leisha, do you want to go first?
Okay, all right, we're starting at this end of the couch. So I'm an oncologist. I take care of cancer patients, and my focus is in lung cancer. And my research interest is in trying to understand how we can screen for cancer more effectively and how we can know who's at risk. So in lung cancer, I think that our notions of who might be at risk for lung cancer and who might not are still kind of stuck in the last century. The risk factors all seem, in people's minds, all circle around smoking cigarettes. And it's kind of, we've painted it with too broad of a brush in that if you're someone who has smoked cigarettes, you are at risk for lung cancer, and if you have never smoked cigarettes, you're not at risk, and it's just kind of binary. The reality is much more complicated, and especially in today's world, the risk factors are changing. In fact, the World Health Organization says that air pollution is probably the number one risk for lung cancer around the world. And so we're screening people for lung cancer, at least in the US, but we're doing it in what I think is a very old-fashioned way. It's based solely on your cigarette smoking history or absence thereof, and we're missing a lot of lung cancers. In fact, if you look in the oncology clinics and see patients coming in with a diagnosis of lung cancer, less than half of them would have been eligible for screening. So we've worked with some computer scientists from MIT to develop an AI algorithm that looks with a fresh eye at a CAT scan of the chest, has so much information on these 3D radiology images. And traditionally, we use radiology to figure out what's happening with a patient right now. I have a cough, I have a fever, we get a CAT scan, and there's a pneumonia. But we don't necessarily use imaging to predict what's going to happen 3, 4, 5 years down the road to that patient, even though there's so much information about how their lungs look and what state of health or disease might be there. So using this AI algorithm, we were able to predict who might get lung cancer in the future 3, 4, 5, 6 years down the road, and who was at low risk. And if we had that better kind of understanding with a very fine detail of who's at risk, rather than the broad brush of just have they smoked or not, we might be able to find more cases at the early stage when cure is possible. So that's what we're working on. Our algorithm is called Sybil, and it's been a lot of fun to collaborate with radiology and with computer scientists to try and figure out how to bring this to patients.
Do you have a prediction on when we will actually use it in patients in the real world?
Well, I think what we're studying now in our clinical trials is exactly how to intervene in the current setup, which in my opinion is not an ideal setup, but we have to take baby steps in medicine. We first have to improve upon existing processes before we, completely erase the slate and start with a new process. But I can imagine a time, maybe 5 years in the future, where we start to recommend most people get a CT scan to assess their risk instead of us predetermining whether the risk is high enough. And then based on actual data from the inside of the person's body, we can say, okay, you are at high risk, or actually you're not at high risk, and move forward with a screening program that's more personalized.
Yeah, and I think that's the key, right? A more personalized, fine-tuned approach to our screening and our risk and our kind of risk mitigation than what we can do today with the tools we have. So, Alex, totally different area of medicine, but equally as important, maybe if not more important, from a global perspective, mental health. Tell us about what you're doing.
Yeah, there's definitely some differences, actually a lot of similarities as far as personalized medicine. I think that's a big thing where AI is going, and mentioning reconciling this in baby steps, right? It's hard to do in that, medicine, it's do no harm, and in computer science, it's move fast and break things. And so you have to reconcile these two. That's the tough thing. That's our challenge that we have to do at the same time. We don't go breaking things. But one thing we're working on is personalizing care for behavioral health. In that, in mental health treatment, there's many treatments that work, but they're not really precisely assigned to patients. And they're usually pretty lengthy and intensive. So it's often about 12 weeks. And so that's really tough if you're a patient, right? 3 months, I don't know if I look at that as a number on a research paper, it doesn't sound like a long time. I mean, 3 months is Christmas time. And so if you did a treatment that doesn't work until Christmas, I'd be pretty frustrated. But the thing is, we don't really have a guide right now of which treatment should work for which person. It's kind of this guessing game, trial and error. There's frustration, there's side effects that are unnecessary, there's many things that go with it. And so one thing we were talking about actually on the way in here was, what do we do with neuroimaging? It's generally seen as mental health disorders or disorders of the brain. Thing is, there's really no brain assessments in the clinic that you see in 2023. And we're trying to change that. So what we've been doing is we're doing brain scans before people start treatment for obsessive compulsive disorder. And we're using AI on it to find subgroups of people who are more likely to respond to a specific type of treatment. In fact, we've found one group of people are much more likely to respond to psychotherapy based on their brain scan. In fact, their brains look kind of more like a healthy person's brain who might not be experiencing broad dysfunction. Whereas the other groups might have had broader dysfunction that might need something like, there's something called transcranial magnetic stimulation, which provides more direct stimulation. And so the idea is, how do we get treatment right the first time for patients without all the time, effort, and expense? But again, integrating into clinical practice is tricky because you have to network in the whole system. Like the brain scan might cost $1,500. We have to go and say, well, we just saved you $1,500 in wasted care, but these are the arguments that we're working to make right now.
Another great area for personalized medicine. And more broadly, right, than even the domain that you work in, thinking about how do we tailor our interventions, right? Leisha was talking about tailoring risk assessment and prevention. You're talking about tailoring intervention and treatment to the individual. And then, Bharti, you work in a very sensitive area for many of our patients. Talk to us about that.
Yeah, so I, as you know, being radiologist, as I was challenged that I would lose my job, I started my AI journey actually very early. Started in 2016, my very first project where I was looking only, at that time AI was supposed to be only my assistant. So I was looking at these images. So as an emergency radiologist, my goal is to diagnose things quickly and and accurately so that I can make the diagnosis and patient can get out of ED. But so while you are so busy, you have so much volume of imaging coming, and it's easy. Your fatigue dies over time, especially if you're overnight, not really physiological hours. You start losing, and you make mistakes, and these errors can cause a lot of problems down the road. So my first project was on cervical spine CT, looking for fractures. So I trained, of course, I spent a lot of hours, actually many, many months, training that algorithm to detect fractures. So I completed that, handed over to an industrial partner. And as I was this is the time AI started becoming quite robust. And this was like after 2 years. This is where I started bringing the superhuman qualities of AI. And one aspect was domestic violence, so intimate partner violence. So as radiologists, we do a phenomenal job when it comes to non-accidental trauma in children. In fact, I can lose my license if I don't diagnose non-accidental trauma or child abuse in children. But when it comes to adults, we just don't have those kind of rules. Adults are supposed to advocate for themselves, and I simply report findings. And we know it's not true. There is a huge social stigma. There is a reason why these patients don't share the hidden domestic violence issue. And unfortunately, because of this, each year in our country, more than 30% of female homicides are linked to intimate partner violence. And globally, it's more than 55%. So we know these, and more importantly, research does show that these patients do come to emergency department within 2 years of, prior to their tragic events. So this is definitely very concerning. And once I understood this, again, working with clinical teams, once I understood this unmet need, I started looking at the radiological findings. So we do have access to all historical imaging data. If I'm reading head CT, I can definitely check on my historical imaging list that patient did have wrist X-ray few months ago, had this kind of fracture, which is again linked to intimate partner violence. But normally I don't have time. In fact, if I spend like more than a minute on X-ray in ED, I'm already feeling guilty. So I really needed someone to integrate all those findings and just bring that to my table. Like, by the way, this patient also had these injuries in last 3 years. Do you want to raise that concern? So this is the tool I'm building based on all historical imaging data, because normally we don't have time to look at it. It's just not possible. We are too busy addressing the urgent need. So if AI can do that, this is the superhuman quality I keep talking about. And then, so we built this tool based on radiology reports. So all historical radiology reports giving me the injury prediction and IPU prediction. But as we got better, I started integrating medical data. So there is so much wealth of information in EMR. So how about I integrate EMR data with radiology reports? And then lately, very recently, I've started looking at the social determinants of health, social and behavioral determinants. And then again, going beyond using the advantage of radiomics, I'm actually interested in seeing elderly falls, why some patients are falling again and again. Again, bringing imaging and clinical indicators. So definitely going beyond simple assistance from AI.
And it really is the power of the data, right? It's the moving from our manila folders, which we all used to have, and most people no longer have, like don't even know what they look like anymore, right? Our current trainees. But moving from that to an electronic health record where we have all the data. I used to think the EHR was kind of the ultimate goal. It's actually how we harness that data, right? And AI is going to let us do that in really new ways that we were not able to do before, even with the kind of analytic AI, right? That itself is evolving as well. I think one area that's incredibly important, and you talk about the superhuman power of AI, is to actually help us see what we can't see ourselves, right? And so now I'm going to shift us a little bit to talk about equity. AI, like many technologies, has the potential to be a double-edged sword, right? Could either, if we're not careful, perpetuate existing inequities that we know exist in healthcare and, in fact, in all walks of life, and even some inequities that we don't know exist. But if we do it right, if we harness AI and that big data to be superhuman, we could actually use the AI to reduce those inequities and address kind of our inherent biases that we have. Can you talk a little bit, Bharti, maybe I'm going to go to you first actually about this because you were just talking about it, a little bit about what you're doing in your research and in your practice to try and use AI to address equity. Yeah,
no, wonderful question. So as you know, I started early. At that time, I wasn't aware of this bias. I just thought if I'm a fair person, I'm including everyone, it should not be an issue. But one thing I didn't realize, that bias can creep in, this unconscious bias can creep in your model right from conception. So look at your pipeline. When you are proposing what is your problem statement? Starting from there to all the way deployment, every step, this unconscious bias can creep in and make your model biased, despite taking all precautions. So this was hurtful. So I didn't realize this in the fracture detection because it was all images. But later on, as I started working on intimate partner violence, I started realizing that it's so important that there is disparity. Of course, we know who is getting imaged. So there are certain patients who don't even get imaged, whether this is unconscious bias or access to healthcare or even sparing time to come to get those images. So there's definitely this kind of discrepancy. And then I'm building model on it. So no wonder I have those images so my model is actually seeing images of only privileged folks, but I'm missing images from underprivileged, underserved communities. So that was a big reason. So I remember this was a few years ago. It just occurred to me that despite taking all precautions, there are certain things I'm just going to lose because it's not possible to have exact same kind of matching. So for example, my pilot data, for example, when I did the overall accuracy of the tool, it was great. I had 95% specificity. I was very happy. But then when I started looking at only Black population, only Hispanics, I started seeing how my model was doing poorly. And then I went back to my database and I realized, okay, I didn't have good representation. These patients were not coming for imaging. So again, I learned it hard way. And then I started, so this is the most important thing, like make sure that you have representation of all diverse populations. So we definitely need that diversity, inclusiveness of different population. And of course we have issues with privacy. Ideally, it would be great if we can have publicly available data, which is all diverse and inclusive, and all of us can contribute. So this is the biggest issue. And then, of course, we also see that aggregation bias. I just told you, my tool was great. I'm like very happy reporting that accuracy. But then once you start looking at the subgroups, that population where the disease actually happens, you start realizing that your tool is not doing good. And then there are multiple things I'm sure they'll talk about that missing data. We don't, so the person in wheelchair, I don't have information on weight, so I'm just going to skip it. Somebody who is unable to speak in English, so I don't have that information, and we are skipping that information. But I'll let you speak because there's so much, and we have to be aware of it. Most importantly, to be aware of bias, that it's going to happen and how to mitigate it.
And to look for it, right? Yes. To look for it and then put in place mitigation. One thing you talked about was there are certain sectors of the population who don't or can't show up for care. And one thing we know in cancer care, right, is that there are incredible disparities in who is being screened and also outcomes of treatment. Talk a little bit about the work you're doing that is trying to address that.
Yeah, this is not unique to lung cancer, the world that I live in. It's across the cancer spectrum where we see huge racial disparities on who goes on clinical trials, who gets access to the newest treatments, who gets genetic testing, which in these days, cancer is really dependent on getting these fancy and expensive genetic tests so that you can match personalized targeted therapy. Across the board with cancer, there are disparities, and that's just in the US. When we look globally, there's massive disparities in cancer as to who's even able to access some of these advanced imaging and certainly advanced genetic tests, and which treatments might be approved in different countries that people live in. So it's very inequitable in the current state in cancer. I do think that having the ability to use some of these tools, especially imaging that can be interpreted in different ways, could be something that could be done globally. I mean, we were talking about the radiology workforce shortage. That's very big problem across the world. And if we can use AI to take care of some of those problems, I think it could be helpful. In lung cancer screening in particular, right now we do know that our current screening guidelines are woefully inadequate for Black women in particular, who are at risk for getting lung cancer with much lower tobacco exposure and at much younger age. So our current screening, which requires that you be 50 years old and have accumulated a certain amount of smoking history, misses the majority of Black women who get lung cancer. And so the U.S. Preventative Services Task Force, which is this committee that helps us set policy for screening, they've recently adjusted the lung cancer screening guidelines in response to that data to try and make it more equal. But it looks like the early days show that there's still a race disparity, and so we need to do even better.
Again, a kind of policy implication, right, for needing to look for disparities and then mitigate them.
Yeah.
Alex, your kind of foray into using AI to mitigate bias?
Yeah, it really sits at the nexus of these points of missing data and how do we create equity. And one thing I was mentioned was addressing the bias. And a big problem is that most AI models today are what are called black box models, which means you get a prediction, but you don't know what happened in the middle. And this is a real problem if there are problems you want to fix. And so how do you correct the bias becomes an issue. And so if there are problems in the model, what do you do? Especially in the self-driving car space, there's been a few high-profile accidents where, with the automated Uber cabs, and nobody knows what happened. We still don't know 5 years later what happened. I mean, frankly, in San Francisco, they have these cabs going around now where they're automated driving. I mean, I'd make these algorithms, and if I saw that cab come up, I would think twice before stepping in. So it's one thing is, the problems, if the models break, how do we fix them? And if they create bias against various demographic groups, how do we know? And we can't just look at the outcome. That's way too late in the game. We need to know in the process, how is this bias happening? Is it missing data? Is it that where you have samples that we haven't collected that are representative? So one point I'd make is that we're talking about AI, and that's a critical thing. But what's equally important, and is not as exciting, is the quality of the data that go into the model. If your data are not right, then your AI model is not useful. And there's different ways of thinking about this. The stat from 10 years ago was 80% of the world's data was created in the prior 2 years. Then 2 years later, that was true. Then 2 years later, and still true today. And I think sometimes, in healthcare, there's a lot of messy data. And frankly, if I put my opinion out there, sometimes it's easier to start from scratch than go back and clean up the old data. Because if we're just creating so much data anyway, let's create it right the first time for our newest models and fit it in, as opposed to trying to reinvent the wheel.
That's great. One thing that you brought up was the black box of these algorithms. And that can instill some distrust, mistrust, fear. Talk to us a little bit about that, Alex, because I know it's a passion of yours.
Well, it should. But in healthcare especially, again, I think the healthcare culture is very healthy here. So when people are worried about, is my provider going to use this, or is this thing going to diagnose me wrong? Jeffrey Hinton was saying, this time, all the radiologists' careers are going to be gone. I don't know about you, any radiologist I know has too much to do. And my friend who wants to work in Hawaii and read, overnight images all day, he sounds like he has a pretty nice life. Sounds like a pretty good gig. I should do that. But with regard to this, then, putting it all together, tell me a little bit the focus you're thinking along this line.
So I think, trying to understand how we implement these models, right? Some of the challenges around them, we've talked about missing data, we've talked about lack of diverse data, we've talked about having populations to implement them on and understanding the kind of clinical milieu of that, but the acceptance of it, the acceptance of using technology to deliver healthcare.
I mean, for the foreseeable future, it's going to look more like augmented reality than true artificial. There's always going to be a person in the middle. So it's really going to help the person do things better, faster, more accurately. But there's going to be someone who's an expert still in the middle for as long as we can think.
I couldn't agree more. Right? We typically use the tagline of human in the loop, right? And that's certainly the approach we've been taking at MGB as we embark on some of the more administrative tasks. One last word from each of you. What's the biggest challenge facing AI implementation in healthcare today? Bharti?
Biggest challenge, of course, data set, how to have this diverse, inclusive data set. And ideally, it should be publicly available. So that's definitely.
Alex?
Okay.
Sorry.
I have a lot more to add.
One word.
Quality of the data, especially like we have some work that shows that even small deviations in the data can cut the model accuracy by 80%.
Leisha?
I think education, understanding for the public, but also for the providers. Hollywood hasn't helped us with these computers that take up arms and take over the world. That's not what we're talking about. Education will help.
Great. Thank you all for joining us. Thank you to my panelists for a wonderful discussion. Thank you to the audience for your participation. We hope that you enjoyed today's panel and that you continue to enjoy the rest of the Globe Summit 2023. Thank you.